Good morning, everyone, and welcome to Monty-Art. Today we have the honor and the pleasure to have Dr. Kim with us. He's a worldwide expert in the field, especially in the field of TAVR. He will talk with us about a very timely topic, which is the importance of valve underexpansion. And we will see why this is important. And all of us, we need to know this when we are performing TAVR. Thanks, Kim. Please go ahead with your talk.
Yeah, first of all, Andrea and Azim, it's a big pleasure and honor to be here, to be invited. I have to say, New York is actually a city of my dream. So you are very privileged in that place where you live. I mean, I have been to New York in February this year, and it's such a wonderful city. And I guess all of you have a house with view on the Central Park, probably. I don't know, but nevertheless, yeah. And so the topic I'm going to talk about is valve underexpansion. Actually, it's the study results that were derived from the IDE study, and most of you will know that the IDE results have been more or less disappointing. They have been presented this year at TCT, the IDE study of ACURATE comparing control competitors, including Sapien and Evolute, was negative. And this was the main reason why a deep dive started. And this was related to valve underexpansion. And but before we did that, we actually had some evidence. And this is a study from where Vinny Bapat was involved and Paul Soraya. And I think it was a multi-center study, prospective, and they collected systematically full cycle CTs after a performance of TAVR, and they compared self-expanding devices and balloon expandable devices. And the main finding was that those patients that had frame underexpansion had a high risk of halt, and this halt, as you can see here, was associated with worse outcomes, clinical outcomes at 1 year. So it affected even all-cause death. As you can see here, cardiac death was increased among patients with halt versus those without halt, but also other factors were affected. Hospitalization didn't reach significance, but there was a signal. So there is another study by the group from Rix from Copenhagen, and they also found that underexpansion, especially regional underexpansion of THV, also studied on full cycle post-TAVR CTs, is associated with more incidence of halt. But in this study, it was a relatively small sample size, and they were not able to link this occurrence with clinical outcomes. And I think at that time, they wouldn't have thought that this is somehow related to clinical outcomes. And you know, there's an ongoing debate on whether halt is clinically relevant or not. And there was one meta-analysis suggesting that halt could be associated with high risk of stroke, but this is really very controversial. Raj Makar recently published a study on underexpansion, on the impact of underexpansion using a balloon expandable valve among patients with bicuspid aortic valve. And, you know, with the complex anatomy, and this has been also shown by Yoon a few years ago, if you have very complex calcification pattern with asymmetric calcification, then you have worse outcome at 1 year. And this is the surrogate, I think, that could explain why those patients have worse outcome. And you can see that likewise, underexpansion and THV deformation is associated with worse clinical outcomes. So this is what we know. And we have also seen the notion of valve underexpansion in self-expanding devices related to the Evolute platform. We have seen that there can be this phenomenon called infolding, and this is probably also some form of underexpansion. Now, I've told you that the IDE outcomes comparing Accurate versus Sapien or Evolute were negative. So non-inferiority was not met in terms of the primary endpoints. And this led the investigators and the engineers of the company to make a deep dive analysis. And so post hoc analysis of the IDE trial was performed. And this showed that there was a proportion of patients among the Accurate Neo 2 group that had underexpansion. And this underexpansion occurred in 20% of the population. And patients with underexpansion had worse outcomes at 1 year. You can see here on the left-hand side is a bench test example of a well-expanded Accurate Neo 2 valve with the mid-stand frame here. And you can see the three commissure posts and the stabilization arches. And the leaflets, they are here in this region. So it's a supraannular valve. And you can see when it's well expanded, this is just a still image of a pulse duplicator that shows a well-functioning valve, or supposed to be. And here is a bench example of what happens if you have frame underexpansion. And this was derived from a real example, from a real case using post-TAVR CT. And this exactly looked the same. And you can see that there's some frame underexpansion, and the way we can recognize it, that the commissural posts, they are not parallel when you compare it to the left-hand side. And on the pulse applicator, you could see that there is a major impairment of leaflet function and probably also integrity. And this would translate, if you look at the outcomes, among those Accurate patients with underexpansion versus those without, there was a significant difference. And those patients that had no relevant underexpansion had almost similar outcomes as the control group, as you can see here in terms of death and stroke. This was shown by Mike Reardon during TCT. So nonetheless, the results that were shown in the IDE trial of the Accurate platform were not consistent with what we found in Europe. And Azim and Andrea, you have been very familiar with the Accurate platform for many years. We have been using it in Europe for more than 10 years. And so we generated data from 3 European high-volume centers. As you can see here, this has been recently accepted in JACC intervention. And those 3 centers were centers that were both experienced with the use of Accurate Neo 2 and Sapien. So was all participating centers were experienced with both platforms. And we studied around 2,000 patients. Of course, we had to do one-to propensity matching to account for selection bias, which obviously is there. You will not be able to completely eliminate. But after matching, we had 702 pairs with a very good distribution of baseline characteristics. And you can see in this comparison that at 1 year, using the same endpoints that were used in the IDE trial, there were similar outcomes regarding the primary endpoint, all-cause mortality, stroke, and rehospitalization. So the question is, why do we have differing outcomes? And this is why we also looked at the phenomenon of underexpansion. And this is data that is under review. And we did the first revision now. And so this was the main reason to review our European Accurate Neo 2 data regarding underexpansion. And here we had to use data from other centers because this required final angiograms obtained in the 3-CUS view, because this was how underexpansion was assessed in the IDE. So we wanted to have the same methodology. And we were looking at, we were reviewing all angiograms and looking at midframe underexpansion using the same primary endpoint composed of mortality, stroke, and rehosp. And this is how we defined underexpansion. And as I showed you in the first two slides, if you have underexpansion, you can see it in the way the commissure post when they are parallel, you have full expansion, and when there is a non-parallelism, if they are misaligned, then you can assume that there is some degree of underexpansion. And in the first hand, we did just visual assessment of underexpansion, but to have a more standardized approach, we defined non-parallelism indicating midframe underexpansion as crossing of extended line of the three commissural posts, as you can see here. So this is an example without underexpansion. All three lines are very parallel to each other, whereas here on the right-hand side, you have a very obvious misalignment, and those extended line would cross within this pre-specified rectangle. And this is how we, for the IDE and our European retrospective analysis, defined midframe underexpansion. So here's the study flow chart. We had patients included between 2020 and 2023, and 604 patients of two centers. We also included Rick's Hospital patients. And after initial deployment, we saw that around 80% were fully expanded, whereas in 17% there was underexpansion, and in 3% we could not assess underexpansion because there was no image just before postdilatation. You can see that in both groups, postdilatation was performed, and the main reason at that time for postdilatation was either PVL or increased gradients. And of course, if there was very severe, obvious underexpansion, then of course we also proceeded to postdilatation. But this notion of midframe underexpansion was not known to us at that time. And so here in this group, postdilatation 117 patients for PVL or increased gradients. And also among those patients that had, in the hindsight, obvious midframe underexpansion, and this was evaluable in 100 patients. Around half of them underwent postdilatation, and the other half did not receive postdilatation. You can see that those that receive postdilatation, in most cases, midframe underexpansion could be reduced or eliminated. So in the final assessment, we saw a rate of midframe underexpansion in 9.4% versus 90% without midframe underexpansion. Let's look at the baseline characteristics. Some of you will say, okay, probably those with midframe underexpansion were sicker, had more comorbidities, or had a higher calcium burden. And you will see that we didn't have to do any matching because the two groups were similar in all baseline characteristics regarding age, sex distribution, risk scoring, and so on. Also, anatomical factors were similar, comparable sizes, annular sizes. And here you can see that the calcium score was similar between the two groups, no difference. If we look at procedural outcomes, you can see also no difference regarding sizing and pre-dilatation, but among those patients with midframe underexpansion, the rate of postdilatation was much lower than in those that had no underexpansion. And what we also saw that the rate of commissural misalignment was higher. You must be aware that at that time we started doing routine active commissural alignment after maybe 1/3 of the cohort. So in the first 100, 200 cases, no commercial alignment was attempted. This explained the relatively high rate of commercial misalignment in both groups, actually. All other factors were more or less similar. And here you see the in-hospital outcomes. And this is remarkable because you could see that there was no signal regarding the immediate outcomes. Technical success was similar. Device success at 30 days was the same. And all other outcomes were similar except for more severe PPM in those patients with mid-frame underexpansion. All other outcomes, pacemaker, etc., were similar. If you look at the one-year outcome, and I told you that we chose the same outcome primary endpoint as in the IDE trial, and it was all-cause mortality, stroke, and rehosp. You can see that there was a very early segregation and very distinct segregation up to 1 year. This was highly significant. And I assume that this was in the early phase, mainly driven by more strokes occurring in the first 2 months, as you can see here. I don't know whether you can read it. This was also significant. And also ongoing segregation regarding all-cause mortality up to 1 year. For rehospitalization, there was only a slight signal. But please be aware that this mid-frame underexpansion only represented 9%, but drove a disproportionate number of events. So the overall rate of stroke was actually not that high. It was around 3 or 4%. And also all-cause mortality was not 20% or 25% in the overall cohort. But only those that had mid-frame underexpansion had much worse outcome. So this is a very, very strong signal, despite of the retrospective character of this study. And so the question is, what can we do about it? And as I told you, at that time, when we did the procedures, we were not aware of the relevance of mid-frame underexpansion. And this is the reason why in around half of the patients that had initial mid-frame underexpansion, no post-dilatation was performed. Nowadays, we would do differently. And you can see that among those patients that after deployment had underexpansion, when post-dilatation was performed, you can see that mid-frame underexpansion could be mitigated in more than 90%. So post-dilatation, if it is performed, seems to be very effective to reduce underexpansion. And how does it translate to the primary endpoint? Here you can see that those that underwent post-dilatation, here in red, versus those that received no post-dilatation, had much different outcomes at 1 year regarding the primary endpoint. And there was an absolute risk reduction of almost 30%, which would translate into number needed to treat of 4. In contrast, among those patients that had no primary underexpansion when post-dilatation was performed, either for PVL or increased gradients, there was no penalty, as you can see here. And this was also true for the single endpoints, all-cause mortality. There was some segregation, and also for stroke at 1 year. Whereas those patients without underexpansion had no harm when post-dilatation was performed. The reason here we look at the predictors of mid-frame underexpansion if we are asking ourselves, what could we do? And what we can do about it, obviously, at least in this cohort, is that we perform post-dilatation when we recognize underexpansion. And another factor seems to be that we should try to obtain commercial alignment for a better expansion. All other factors that you can see here, baseline and procedural factors that are also not shown, were not relevant. Yeah, this is another analysis that we did to show the efficacy and safety of post-dilatation, also in a relatively large cohort retrospective in terms of accurate NEO and NEO 2,500 patients. And we showed that even when the balloon size is larger than the annulus, and sometimes in the very early phase, we did it. Nowadays, we should not do it, but yeah, it seemed to be safe. Maybe there was a balloon 1 millimeter exceeding the annulus size. But you can see that overall, post-dilatation was efficient and relatively safe. And if we look at predictors of successful post-dilatation, you can see that an effective or more aggressive pre-dilatation could contribute for more efficient post-dilatation. Here's an example with the accurate prime. I don't know whether you participated in the IDE and already have experience with the prime platform. And you can see after the deployment, there was no leak, obviously, and also on pressure tracings, there was no gradient. But you can see that we were not satisfied with the configuration of the stench frame and the commercial pose, and you can see what it looks like before. There seems to be some deformation here, and therefore we proceeded with post-dilatation, and after that, still no gradient, no leak, but obviously better expansion with more parallel posts as compared to the initial deployment. Now, of course, we cannot compare the two studies. One was prospective randomized. I don't have to tell you, 700 patients, and our European data that we looked at retrospectively. You cannot compare those data, but maybe to trying to explain what could have been the difference. And first of all, of course, another study population, different age, all patients had to be selected and screened by a CRC committee. I was part of the committee. And pre-dilatation was much more common, admittedly, in the IDE. And this is 87% of pre-dilatation, but this is my personal opinion or interpretation that pre-dilatation probably is not necessary in all patients, but if pre-dilatation is necessary, it should be performed appropriately with the correct size. And you can see that the sizes of the balloons used for pre-dil and post-dil were much smaller in the IDE than in our European experience. And so our average balloon diameter that we use for pre and post-dil is around the annulus size -1 or -2, depending on the degree of calcification. And I'm even more aggressive. If there's a lot of calcification, I would expect a worse expansion and the necessity of post-dilatation, and I'm relatively aggressive. So annulus -1 is our routine approach. And also for post-dilatation, you can see that the balloon sizes were much smaller. And as I was part of the screening committee, I can tell you, after scope 1 and scope 2, that were also negative, my expectation was if we have a good sizing of the accurate, then everything will be okay. But of course, we didn't expect that the ballooning would be so inefficient. And in terms of the screening committee, we made clear recommendations regarding the size of the valve, but also of the balloons that were used. And obviously, you can see it probably when the publication is out that those recommendations were not followed. For instance, if a 22 millimeter balloon was recommended, frequently just an 18 or 20 millimeter balloon would have been used. And of course, at that time, no one was aware of what underexpansion really means. Yeah. So Yeah, what do we do? I have also started to look at post-Tower CTs, and you can see that there really is a surrogate on post-Tower CT. You can see that the stand frame and the commercial poles are not really parallel, and this is the correlate on post-Tower CT. You see huge under expansion here at the non-coronary cusp. The same here in this example. This could translate into halt and leaflet motion abnormalities. Here you can see that there's a compression of this area here due to a very severe calcium nodule. On the other hand, here you can see on the right-hand side what it should look like when a valve is really uniformly expanded here at the level of the waist. And this is what it should look like also on the angio. So I would like to summarize. We were able to show in this European cohort from 2 experienced center that midframe underexpansion occurred despite of very good practice in 9%, which was around half of what we saw in the IDE. And yeah, maybe just a comment that there were different methods that we used in this analysis. We used the same method that was used in the IDE, and please beware, assessments were made in the 3-cusp view. If you start looking at underexpansion, non-uniform expansion, and non-parallelism in the cusp overlap view, which is the short axis, you will more frequently see that there is underexpansion, and this could lead to an over-interpretation. So this was validated with looking at the stain frame expansion in the 3-cusp view. So what I would say is, if you see underexpansion in the 3-cusp view, probably it's relevant. If you, it's always relevant. If you see underexpansion or misalignment of the commercial post in the cusp overlap view, it could be relevant, but not necessarily. We have seen that midframe underexpansion is likewise associated with worse outcomes, and you can see how much it's segregated. It was very, very robust, and also using different methodologies and different thresholds of how we define underexpansion. It was very robust in the same signal. What is remarkable is that this can be, if you are trained a little bit, identified during the index procedure, and it can be corrected immediately. This I can skip. And I think this data shows that probably if required, it's all retrospective and hypothesis generating. Post-dilatation seems to be able to effectively mitigate midframe underexpansion and could improve outcomes. On the other hand, if we perform post-dilatation even without underexpansion for other reasons, if necessary, there was no signal of harm. So my conclusion is that operators need to be aware of the consequences, of the midterm consequences, not immediate, but midterm of underexpansion, and therefore should be able to recognize it. So maybe the threshold to perform post-dilatation should be shifted a little bit and also should be considered in the event of midstream underexpansion, and this should be done irrespective of gradients or PVL. So thank you very much for your attention. I'm very happy to further discuss. I think this is a topic that relates to us every day, and that we have seen also in the coronary field. And if you see what we do in coronary, and Asim, you have been one of the pioneers with imaging. Yeah, we do lesion preparation. We do very meticulous calcium modification, and what we all do in order to achieve a good stent expansion. We do post-dilatation, imaging, and maybe we should change our mindset also in the field of TAVR.
Yes, we fully agree. Thanks so much for the talk. I mean, you have such a great experience on self-expanding valves, especially with the accurate platforms. So we all have to learn from you. So we have like many questions for you. Maybe I will start with one, and then we will see if someone else has more questions. So you actually went over many, many important points in how to properly implant valves. One of them is a proper pre-dilation, which is needed in most cases. So what's your like your practice? What is a proper pre-dilation for you? Do you use the mean, the average diameter based on the perimeter minus something, or what do you usually do?
Yeah, very good question, Andrea. Actually, we had a publication a few years ago where we showed that even without pre-dilatation, you can achieve acceptable outcomes. But I have changed my approach now because I have seen one patient where I uh, didn't perform pre-dilatation, and on the angio, everything looked good. But this patient came back with a stroke, and I saw that there was major underexpansion that we didn't see on the angio. It was several years ago. And since then, I changed my practice. And I think that pre-dilatation, I do 100% pre-dilatation now, even with my classification, because you don't know whether there's some fibrosis. And my practice is, as I told you, I'm very I'm very aggressive. I take the annulus parameter-derived diameter and usually subtract -1 or 2, depending on the degree of calcification. And the fear that we have, the concern that most operators have, is that we do damage to the annulus and or have a leaflet here. The first one I've never seen with careful pre-dilatation. So in the series of accurate that we did, in the meanwhile, I think we did 4,000 cases now, and I've seen zero annular rupture with this aggressive pre-dilatation regimen. No annular rupture because you stay below the average diameter, right? And what we do every day with Sapien, if you have a 24 millimeter Sapien, 24.5, then probably everybody would use a 26 millimeter balloon device. So you have always some overstretching, even with Sapien. But when we use Sapien, we do not question it. Of course, we have a stent and covering everything, but I think that probably in terms of annular rupture, in most cases, in utmost cases, even a larger balloon size, if you stay below the average or parameter, whatever, diameter is safe. Of course, you can have very ugly, complex calcifications, very severe LVOT, then you have to be careful, of course. But in most cases that we have seen, and we look back at around 4,000 cases, with this aggressive approach, there was no annular rupture. And maybe from your experience, if you don't use a 2 or 3 millimeter larger balloon size, then I think the risk of annular rupture is very small. The other concern is more justified. You can have, if you have larger balloons, you could have severe AR. And in this case, what you can do is you have to put the patient on pacing to mitigate the hemodynamic effect of AR and immediately implant the valve. And usually, if you have a very experienced team, I would say you can do it within 1 or 2 minutes with this platform. So this is what I see from time to time, not
And
frequently, but
and
in
keep
most cases, it's not very severe. It's just a hemodynamic compromise to some degree, but not a full hemodynamic collapse. Yeah. And so yeah, and you know there is no data showing that we need to respect the minimum diameter. This is what Medtronic teaches us, right? Without having any evidence. But I think for Medtronic, for this platform, it may be okay because the opening force and the final radial force is a different one. But if you have a platform with not such a big radial force, then you have to have another. Sorry, I interrupted you.
Yeah, no problem. Now, I was just going to ask, I mean, so you mentioned, people get worried about aggressive pre-dilatation for pre and post. Let's put them together, all right?
Mhm.
Because in the end, I think the risks are the same. They get it. You mentioned aortic injury, which I agree with you. I think is pretty rare. I mean, it can happen. I've seen it happen with pre-dilatation, but again, like you said, it's more usually when you have some um, challenging patterns of calcification that may be
Mhm.
put into the alveoli. We talked about AI, and in most cases, you just get the valve in quickly and you'll be okay. The other two issues well, three issues people bring up, and maybe we can address them one by one. And this is what you see discussed, right? Is neurological events, because the more you manipulate the annulus and the valve, the higher the chance of embolization. Two, and not maybe with this valve because of the way it's open, but the second one is coronary obstruction.
Mhm.
Okay. Is particularly when you with tall valves, core valve, Navitor, are you pushing the leaflets closer to the coronaries? And then the third one that keeps coming up, and again, I want to hear your experience because the evidence is minimal on this one, is are we damaging the leaflets by repeatedly ballooning it, especially with the post-dilatation?
Absolutely good comments. And I think you're really right. We do not know what we do on the long term with the leaflets. Yeah.
Yeah.
But at least on the midterm, if you look at this, if you have underexpansion and you do not do something about it, then obviously the patient is doing much worse. Yeah.
Right.
And this is what you can see even here in the entire cohort. And they will have probably a high risk of stroke. I don't know whether you can see it.
Yeah, I can see that.
Yeah.
So
And on the other hand, you were talking about high risk of stroke due to post-dilatation.
mhm,
And you can see that post-dilatation here, even without underexpansion, there was no higher risk of
with the stroke.
post-dilatation, at least in this group.
Right,
And post-dilatation decreased the risk of overall stroke.
right,
Yeah. So I
right.
think the risk of a stroke by having underexpansion is higher than the risk of the what we do with the
Stroke from
balloon.
manipulation. Yeah,
Right. Yeah.
right.
This is something you have to weigh. And obviously, at least these data suggest that there is a higher risk not to do post-dilatation
Mhm,
than just to leave it if there is underexpansion.
right.
Yeah.
So, Kim, the one the one other thing I was just struggling with when I look at the data, because the data, most of the data is 1 year data, right? And it's impressive that we're seeing these survival curves change before 1 year. I guess what I'm struggling with, because I also it's just the way my mind works, is a better mechanistic and pathophysiological understanding of why patients are dying. Because I can understand, and we have now a couple of data sets. You showed us the data from Vinny that if you have underexpanded valves, that doesn't matter if it's a balloon expandable valve or self-expandable valve, you're going to have a higher risk of halt.
Mhm.
Okay. None of the data have shown that. It all seems to be subclinical halt still, though it doesn't seem to be halt with high gradients or AI, right?
Yeah.
It seems to be subclinical.
Mhm.
So we have that data. Then we have all these patients dying from cardiovascular causes, okay, but they have halt. And so I'm struggling to make the connection. How is the halt killing people in the future? Because they don't have PVL, they don't have gradients. And pre this data, we had all this other data on halt. For years, we've been arguing at meetings.
Mhm.
What do you do? Do you treat halt every time you see it? Do you put them on anticoagulation? One meta-analysis says it has no impact on mortality or stroke. Another one says maybe tiny risk. No impact on thromboembolic events, on NSTEMI or ACS. So what's the missing link? Why are patients dying?
Yeah, I mean, this is only an observation, right? I'm not able to provide you with a full pathophysiological explanation. And the only thing that I could assume, yeah, this is only an assumption. If you look at what happens at between 1 year between discharge and
Yeah.
2 months, you see that the stroke rate increases here.
Okay.
Obviously, in the first weeks after discharge, you have an increased signal of stroke among those with underexpansion. Yeah. So this occurs within the first 2 months. And then my assumption would be probably we know that stroke is associated with worse outcomes. And probably this could be associated with patients that underwent stroke would die over time after they have experienced stroke. But Azim, I cannot provide you with any link regarding pathophysiology.
Oh, no, good, good. As long as you're
What
struggling as well, it makes me feel better
I'm struggling.
that we need to understand, because we need to understand why, right?
Yeah.
And
And it's
how.
only an observation, but what I can say is this is a very strong association that we see because you see how the curves segregate. And we know, and it's in our heads that we know that somehow underexpansion is not good. We have seen it with stents. And if you look at this image, and if you would see moving image, and I think Chris Frawley, this is one of the engineers, could maybe, he has very nice images on bench tests, what happens to the leaflets. And there's creases happening. There's non-uniform opening, and I think this can have impact on the function and integrity of the leaflets, and somehow increase the risk of not only macro thrombi but also microthrombi. And somehow this seems to be related to increase of stroke. But I cannot show you the exact link. This is what we have seen both in the IDE and also in our study. Unfortunately, also in the IDE, they did not have systematic CT analysis after that, only in a small proportion.
Right.
So what we can derive from the prospective data from Vinny is probably there is some association. I've done some post-TAVR CT analysis only in a very small subset of 50 patients that were available. And of course, this is very selection bias and at different time points. What I could confirm is there is some correlation or some correlate to underexpansion. You see it on CT, as I have shown you, but I have not seen halt or other things that you could recognize macroscopically. Because the problem is these CTs were obtained at different time points, not systematically after 30 days and 1 year. Would have been different. So I cannot show you there were leaflet thrombosis or other signs that could directly explain stroke. But I could show you that those patients with underexpansion had these images here on post-TAVR CT, and you can see there is obvious underexpansion, regional underexpansion. Yeah.
So let me ask one more question. Sorry, I'm gonna let you guys go on. I have many questions, but there's one more I have to ask. So we never knew about this. I mean, you admit, even you, someone so experienced, you became aware of this because of the Asian IDE, right? So we were not aware of this. We've been doing Accurate for years and years, and for me, the most, the reasons I post dilated and Accurate was PVL. There was a gradient, or I saw the lower crown where the ceiling is that looked underexpanded.
Exactly.
I never looked at the commissural. I have to
No.
tell, I have to be very honest. I looked
It's
at the
the same
bottom.
with me. Same with me. Yeah.
But now we know this.
This is why I told you, Azim,
Yeah.
at that time, we were not aware of what mid-frame underexpansion means.
Right.
And this is why we did post-dilatation in some of them and did not in some of them.
So let me ask you this. I wanted you actually this picture. On this picture, okay, there you have 57 patients now who have mid-frame underexpansion because we didn't know about it. Okay.
Yeah. Yeah.
Are you going to be calling all of them and putting them on anticoagulation?
Yeah, that's a good question. Yeah. I think it's too late. I would assume that this happens in the first 3 months,
Yeah.
at least our cohort, and then maybe after that time period, it's consolidated,
Okay.
and this will be normalized. And actually, if you look at 2-year data and it's not complete from the IDE, the curves are getting closer, actually, again, after
Right.
this initial
This
dip. And maybe this is also something we saw in scope 1, right? With 3-year data when the lines were crossing.
All right.
Yeah, and so let's see what happens after a few years. I don't know.
Okay.
Yeah.
Sorry, Andrea and Pierre.
No, no, I mean, it's a very interesting talk. So we all have like so many questions. I have a question for you. I haven't seen in these tables, like, I don't know if you investigated this, the amount of oversizing of the valve compared to
Yeah.
the anatomy. And this, the reason I'm asking this is especially in those patients who fit like in the middle of two sizes based on the sizing chart. Sometimes we have to decide for the smaller valve, other times for the larger valve. Do you think maybe if the valve is too large, maybe
Maybe.
it will not be so expanded or maybe not so
Yeah.
circular, and this is not good? Or how can we explore this?
Andrea, actually, this is a very important topic, and this introduces a paradigm change that I'm undergoing with sizing of the Accurate platform. And you may be aware, and to answer your question first, here's a cover index derived from the parameter in percentage. Can you see it?
Yes.
Yes.
You can see it. The sizing was a little bit larger. This was
How
only
is it?
No,
6.7.
6.7 versus 6.1.
Yes. And please be aware that the cover index with the Accurate is not precise because we use the size at the waist, right? The sizes of the Accurate are determined here at the waist. So if we have small, we have 23. If we have medium, we have 25, and large, we have 27 here at the waist. But you
Okay.
know that the anchoring occurs here. And here we have a diameter that is probably waist plus 2 or 3 millimeters. So the cover index that we calculated here is not really precise. Actually, you have to add some more oversize. So this is a little bit underestimated. Yeah, and of course, depends on the depth. And for this calculation, we used the nominal diameter at the waist. So it's a little bit underestimated, but you can see there was no relevant difference. But in my current practice, you know that for the Accurate Neo 1 that had no skirt, we had the recommendation to do oversizing when we were in a borderline zone. So 22.5 or 6, instead of using an S, we would go to M, right? And this was in the borderline zone. And we required this oversizing because there was no sealing skirt in order to reduce PVL. And we had to do this by more oversizing because if you have more oversizing, you will increase the radial force. With the Neo 2, with the skirt, we learned that this degree of oversizing is not necessary anymore. And maybe this was part of the problem. I don't know that, or could be part of the problem that sometimes we choose too large valves that then tend to be underexpanded. And I think the risk of underexpansion, of course, is higher if you have a too large valve in a small anatomy. And currently, I really try to stick to the recommendations. And if I'm really in a borderline zone, so today I have done a 22.9 millimeter annulus, and with the Accurate Neo 1, I would have chosen M, but we stick to Fs, and we had a very nice, very good expansion. Yeah, what we have frequently seen is this V shape due to the oversizing, and nowadays with the skirt and maybe a little bit more better pre and post dilatation, I think you don't need to have this severe oversizing. I don't know how's your observation with Evolute. yeah, or other platforms. I used to oversize more, but nowadays I'm trying to not to be too large because you are more inclined to see infolding or
Yeah,
other problems if
I
you're too
agree.
large. Yeah.
I agree. I think we went too far in one direction, and so I think we're all coming back. And I think also, what you say here about pre-dilatation, I think is important for all valve platforms. Particularly self-expandable.
Sure.
I think we went too far in one direction of trying to do quick procedures. And I mean, I know certainly in our practice, even with core valve, we now pre-dilating a lot more than we used to. Not as much as accurate or Navitor, but definitely more than I was a year ago.
Yeah.
Mm.
Definitely. I think there has been some change in mind
Yeah.
in how we approach these procedures, even with self-expanding devices that obviously have higher radio force than the accurate. But if you listen to engineers, they say the radio force of self-expanding device, they are all in a very similar area. And you have balloon expandable devices that have several times higher radio force. Yeah. So
Right.
you cannot compare it. The advantage of the Evolute is if you see there's infolding or some under expansion, then you resheath it and then you can reposition it. And
Yeah.
this is something like pre-dilatation that you do.
It is. It's definitely a pre-dilatation. Yeah.
Yeah.
Let's get Pierre and Antonella, see if they have any questions. Pierre.
Yes, Dr. Kim. Thank you so
How good
much.
to see you here.
Great to have you here. I'm just following up on Dr. Latib's point. So, like in clinical practice, after valve implantation, there's so many things that we think about that might actually possibly happen after post-dil. So, if patient is a risk of pacemaker, if the valve is very high, and we don't want to post-dil. And as you said, sometimes there's kind of, it looks to me, and that's my understanding from your talk, is that sometimes there's kind of a gray zone, especially when you see under expansion and the three cusp is very bad. When you see it in the cusp overlap, might not be as bad. So I was thinking if you think that some kind of in your study, for example, you divided in under expansion, yes, under expansion, no. So it's a categorical variable. I'm thinking if you believe that some continuous variable that might give us an index, the first one that might come to mind is some kind of ellipticity index, might really help us saying, okay, you have this kind of degree of under expansion, which is asymmetric, you definitely need to do this because you know that the events are going to be so high. And then maybe you have some degree that is less to the degree, and you know that maybe if you have the risk of other kind of complication, you might be well enough just not pursuing post-dil. I was just wondering what you thought about this. And
Very good question. I can show you this. I told you that we tried different methodologies. And the first one that we used in order to be aligned with the IDE method, in order to be able to compare the numbers, was the visual method. We also did more meticulous measurement using non-parallelism. We're a bit complicated to explain it, but we measured the distance between the two stent posts at two different points, and the delta of this difference determined non-parallelism. And we looked at different thresholds, as you can see here. And you can see that there is a linear correlation. And I told you that we use several thresholds defining under expansion. And you can see that the signal on the primary endpoint is very robust, irrespective of the threshold that we use. So here, this is very severe under expansion. If the difference this is like this, when it looks like this, very severe under expansion. Of course, you have stronger outcomes in those, whereas if milder under expansion, as you can see here, you still have a significant difference, but not as severe as in these groups. So this seems to suggest some linear correlation. And now back to your question. Of course, please do not understand these data as a recommendation to do post-dilatation in all patients. No, it's not necessary. I think if you have a post-dilatation rate of probably, I mean, something around 20%, probably it's enough to do 25 to 30% to get rid of those that are really in danger with underexpansion. So it's necessary to really recognize those patients that are at risk, and you have to weigh the risk individually. If you see very mild underexpansion, you are not sure, is it one or not? And on the other hand, you have good gradients, no PVL, and the valve looks very high, then I would not do post-dilatation, at least not in the first 10. It's a very individual decision. Yeah. But if you have no obligations and the valve is in a normal position, but you see underexpansion, sometimes we say the patient is 85 years old. Sure. And then you don't perform post-dilatation. You accept a mediocre outcome. But in those cases, I would say you do TAVR in order that the patient would benefit from the procedure. If you only see underexpansion, then probably I would do it because you don't want the patient to have stroke after two months. This is the only thing that you have to consider. Yeah. There could be an increased risk of stroke if you have this underexpansion. But if you are afraid that, if you are concerned of post-dilatation, you do harm, you do embolize the patient, the prosthesis, or you think that you would obstruct the coronaries, then you don't have to do it. You could just take the patient off the table. If you are in doubt, then you could do CT. And if you see some underexpansion, then you can still decide, should I post-dilate or put the patient on anticoagulation? This is how I would proceed. I would not start to see ghosts in all patients.
I like that.
Start to post-dilate because I mean, very sorry, but you might have seen the live case in London VAS, and they were starting to discuss post-dilatation in the accurate prime. I didn't see the necessity, but the panelists, they started to discuss, yeah, we have to do post-dilatation. No, we just need to have this awareness.
Thank you.
Right. Antonella, last question, quick question.
Yes, so just to make sure, so you didn't see also any correlation between your visual and underexpansion and like higher mean gradient after?
No,
okay.
I can show you. Yeah, and
So
this
maybe
is
I missed that point.
no. Here you can see it, and this is remarkable. Yeah, and this is why IDE. There was a problem with IDE. 38 outcomes were similar, even in IDE. The signal of separation began after 30 days. Immediate outcomes are the same. You don't see it. And this is so tricky about this thing. Immediate, you will be satisfied. You look at the gradients.
Yeah, I see.
The same.
Yeah, that's the same. That's
technical success is similar.
So now my question is a little off topic, but now with all these results, this limitation, could you define a patient profile where you would go with an accurate as your first choice?
Yeah, it's a good question. To be very honest, I would probably
something that you consider that maybe I'm not thinking, and that's express all the potential of the valve.
Yeah, I'm really one of the defenders of having a patient tailored valve selection. I really like this. And I think that this could, if you could show it in some studies, probably you could demonstrate superiority than when you take one valve platform for all patients. And this is what we may have seen in Dedicate, right? In Dedicate, this German randomized trial for the first time saw superiority or lower mortality even at 1 year for TAVR. I think a big point was that we were allowed to select patients, select a platform for each patient individually. And the Accurate has following advantages that I would like to underline. You have a relatively low pacemaker rate. Yeah. You have good gradients, not as good as Evolut, but it's very similar it's in the same order. You have the lowest risk of coronary obstruction, and it is most easy to be commercially aligned. The implantation concept is relatively easy, but if you go more in detail, it's not that easy. So I would say if you had a valve with these outcomes in the IDE, yeah, then everybody would say just discard it. Yeah. If you had this outcome for the Navitor, for instance, then I would say you can discard it because we have the Evolut, right? Yeah, you have similar profile. But with the Accurate, I think you have to highlight it's not a perfect valve. Probably you cannot use it for all patients, but you have right now best-in-class pacemaker rate. You have best-in-class commercial alignment. You have best-in-class coronary obstruction risk. And you have fairly good hemodynamics. And it's really okay for horizontal aorta. So these are some benefits that needs to be highlighted. And that's why I think it is worth looking at why this platform failed in the IDE. Our data, they do not prove that it's not non-inferior. Yeah. But at least they question why there is a discrepancy and whether we can just attribute it to the non-adherence of recommendations in the IDE remains to be shown. I think there needs to be another study, but it's just an example that I give. If you have a DCB study and you recommend 60 seconds of inflation and some operators only inflate for 10 seconds, and then you cannot compare the outcomes, right? Because the device has not been used appropriately.
Yeah. The only problem is this device has been available for years, yet only now it feels like we're learning how to use it properly. We keep learning,
It's
but
a big
that's part of
surprise.
technology. That's part of
It's
technology.
a big surprise.
Yeah.
We didn't know. We
Yeah.
didn't.
No, none of it. Like I said, I never looked at it. I'm glad. I feel better now knowing that you also wasn't something you were looking at before. But it just shows there's so many things we still have to learn about what we're doing.
I have to say, intuitively, we did it a little bit better. Yeah. We did more aggressive pre and post dilatation, but we never have had data to back it up. And now it looks like, it's not a proof, but at least it's a strong association that we see that probably if you want to use this valve, if you want to continue using this valve, then it requires more careful application. And you need to observe some rules, but maybe if you observe these rules, you can be really happy in really a broad field of patients, actually. So in our institution, we use it as workhorse. It's okay also with the Prime XL, but I don't think that you should use it in all patients. I would say it's good for 80 to 90% of the patients. But just show me one valve that can be used nicely in all patients. I don't think there is one valve that's really good for all kinds of different patients.
Yeah,
that's true. Okay, so Kim, thank you so much. We really wanted to thank you for sharing your experience with all of us and Monty-Heart. It was a great lecture, and clearly this is a topic we have to learn more about. So thank you very much.
Yeah, thank you again for having me. It was a great pleasure and honor, and it's very good to have this connection to New York.
It's a great discussion.
Wishing you a very, very nice Christmas with the Christmas tree. And,
Next
Yeah,
time we will
thank you
invite
very
you
much.
presents,
Yeah.
so you can come here.
Enjoy your Christmas, Kim. Talk to you
Yeah.
soon.
Thanks.
Yes.
Bye.
Bye-bye.
Happy holidays. Bye bye.